Hello, Dr. Patton. This is Max, and this is my CAM project reflection video. I chose to treat low back pain with dry cupping. I wanted to do this because I have my own dry cupping set at my own disposal, and it's something I've always kind of wanted to try to do in my own clinical practice. During undergrad, I saw a lot of good outcomes with dry cupping as far as treating musculoskeletal pain and increasing range of motion at the neck, shoulders, and lower back. So I figured this would be a good time to see if I can create the same effect or beneficial outcomes with decreasing musculoskeletal pain. So throughout my literature search, I found that there's a lot of articles about wet cupping rather than dry cupping. And with wet cupping, you make an incision in the skin, and basically the vacuum mechanism of the cup pulls the blood into the cup, and it's supposed to release toxins in the body. But with dry cupping, there's no incisions or anything. You're just lifting up the skin with the vacuum mechanism. Some common contraindications I found throughout my literature search was fractures, pregnancy, deep vein thrombosis, putting the cups anywhere where there's a pulse. We don't want to do that just because, again, that vacuum mechanism can disrupt blood vessels, and we don't want to do that with arteries or veins. And then sunburns, rashes, contusions, and abrasions, lacerations. We don't want to put cupping over any of that. And then throughout my literature search here, there have been quite a few studies done comparing dry cupping with acupuncture. Those articles have shown that acupuncture is probably the more favored treatment just because it was more significant in decreasing pain in patients and slightly improving range of motion. There have also been a few studies on dry cupping compared to NSAIDs. That one's kind of a toss-up, that topic, just because some studies say, dry cupping is more effective in reducing pain than NSAIDs, vice versa. And then there are quite a few articles on comparing dry cupping to no treatment at all or a sham treatment, and dry cupping comes up on top with reducing pain and increasing range of motion. A lot of the literature out there also kind of focuses on low back pain and neck pain and tightness. So those are kind of common articles and locations on the body you'll find the literature focusing on. Moving forward, describing my outcome measures that I used. For the patient-rated outcome measure, I decided to work with the Roland-Morris Low Back Pain and Disability Questionnaire. It's a 24-item questionnaire that focuses on ADLs, functionality, kind of getting around the house, more so of, can you put on your socks? Can you walk up and down the stairs? That kind of thing. And then the clinician-rated outcome I used was the Behring-Sorensen test. Basically, you'll put the patient or subject on a glute hamstring developer, and they'll be horizontal. They'll have to maintain trunk extension for as long as possible. In normal males and females, the average time for them will be about 200 seconds. And males that have low back pain, the average time will usually be about 163 seconds. And in females, it'll be 177 seconds. So I figured that would be a good measure to see if there's progress being made at the beginning of the week to the end of the week using that objective data. So those are kind of the outcome measures I wanted to work with. The Roland-Morris, it's more focused on, are they getting relief outside of their sport or at home? And if it's affecting their daily life a lot, not a lot, not really. If there's any limitations there. Walking through how I went about this project, I used 4 cups on the erector spinae muscles on the distal end, just because the patient was having pain in that area. I put the cups right over the painful areas that the patient identified. The cups were about half an inch apart, and they were left on for 10 minutes. I kind of went back on what I said in part 1, where I kind of moved the cups up and down. I just decided to leave the cups there, just because, in undergrad and in my own kind of practice, I found that patients do not like it when the cups are moved, so I just left them there. And just wanted to see if we would get any beneficial results. So I decided to do cupping 3 days a week on Monday, Wednesday, Friday. I was only going to get 1 patient with low back pain, just because my patient volume was down. This was during the period of fall sports ending and winter sports kind of picking up, not really there yet. So my patient volume was down, and I could only get 1 patient with low back pain. So yeah, again, the treatment lasted for 10 minutes, and then my outcome measures were done before treatment on Mondays and Fridays to track progress from the beginning of the week to the end of the week. So that's kind of how I set things up. I was only able to do data collection for about 1 week because the patient stopped showing up after 1 week, just because they kept forgetting. So that was pretty unfortunate. So the data I found on Monday with the Roland-Morris questionnaire, the patient identified that they are having to change position often just to make their back feel comfortable throughout the day. They have to get dressed slowly because of their back pain, and they have trouble putting their socks on just because they have to bend over with that trunk flexion, and basically that stretching of the erector spinae muscles is causing that pain. Throughout the week, that week from Monday to Friday, the patient still identified with those same 3 outcomes, where they constantly had to change position, and then kind of getting dressed caused them some pain as well. But with the Behring-Sorensen test on Monday, the patient was able to stay horizontal for about 145 seconds. At the very end of that, he was starting to shake because that area was painful, and he didn't have the endurance there. And then at Friday, he was able to actually do 200 seconds, and he was feeling very good that day. And he said he actually could have gone longer if he wanted to. So that kind of gave me a good indication of, the cupping treatment worked, or at least helped in reducing his pain. So I thought that was really beneficial. I would have liked to see this go on for a couple more weeks, depending on how his bruising would be, and everything like that. I don't want him to be very sore from the constant cupping and everything for 2 weeks consistently. The subject did mention that the patient-read outcome measure didn't really relate to him that much, and he probably would have wanted something that related more to just general pain, which I agree with. If he was in like distressed pain where he couldn't function, he would need like crutches or like a walker or something to get around, I think this would be a better questionnaire for that. I think next time I should just use like a VAS pain scale, or maybe like an SF-12 or SF-36. But overall, I would have liked to make this go on a little bit longer. I would have liked to have at least two or three more patients with low back pain to kind of get more data on. I did like the Behring-Sorensen test, but the only issue was that I'd have to section out at least 5-6 minutes to make sure the patient had the proper dressing for it, to get a GHD machine, or at least have, I don't want to boot somebody off of that during their after-school workout or anything. So kind of, making sure that's free for us to use. It was just a little time consuming with that, even with the 10-minute dry cupping treatment after. But again, overall, I would have liked this to go on a little bit longer. I wanted to have at least 2 or 3 more patients, just to get some more data to show if dry cupping really was effective or not. So again, thank you for watching and listening, and yeah, thank you.